I've worked in clinical trials for a long time, mainly in common diseases such as ischemic heart disease and cardiovascular. I work part of my time for FDA Center for Drug Evaluation and Research, although what I'm presenting today doesn't speak for FDA in any way, shape, or form. But in my work in FDA, I'm getting more involved with rare diseases, and it's a fascinating area that has a lot of challenges. So I'm going to start with an analytical overview, and first of all, mention what is the worst possible solution to the problem of clinical trial outcomes, and that is so-called responder analysis. And I've seen sponsors still using this, as shocking as it is. I've seen a rare disease study that had 28 uh, patients total, where the outcome was a nice established ordinal scale, and it was dichotomized into responders, non-responders. So they took 28 subjects and made the effective sample size be about 18 subjects. And so they discarded tremendous amount of information, and you really can't afford to lose that kind of power. So responder analysis is where you define the way you'd like to interpret the treatment effects, such as how many people had their function improved by so many points, or and were still alive, and so on. And you can create some combination of uh, outcomes that you consider a success, and just calculate the proportion of patients that achieve that outcome. That violates so many principles in statistics, it's almost frightening. But the misunderstanding that clinical designers have is that they think that the way you want to interpret the trial is the way the raw data should be transformed to analyze the data. And that just is never a good approach. Another approach that we see a lot is time to event. And people got so comfortable with survival analysis or time until clinical event that they don't realize how limiting that really is. So if you're dealing with a mortality study, so you've got one kind of event, and death doesn't get interrupted by anything else. You can always observe whether the patient's alive or dead. You can calculate the time to death, and that time until death then would be a very important and appropriate uh, thing to analyze. But if you have an event such as hospitalization or a recurrent need for rescue therapy, you're ignoring recurring events by just looking at the time until the first event. You're also ignoring the severity of event if you're calculating the time until the first of several events. So in the field I've worked in, more cardiovascular, it's very common to have major adverse cardiac events, which includes cardiovascular death, hospitalization for heart failure, myocardial infarction, and so on. And then to calculate time until the first of those, that's treating all the events as equally severe, which is a huge loss of information. It actually makes the interpretation of the time until the major adverse event makes that interpretation very mysterious. Another thing that we see especially in more acute disease, is time to recovery. And time to recovery has very, very serious statistical problems with it. One of the problems is that recovery is a good thing, but it can be interrupted by bad things. So when you have time until a good thing, such as recovery, you're sent home from the hospital, you don't need further treatment, whatever. If you're interrupted by something bad, such as death, you don't really know how to handle that. And so the custom is to handle death as a competing risk, and that makes the interpretation very cloudy, and it doesn't count death explicitly as something bad. The other thing you see, such as in COVID studies, where that's actually what I've been working in most the last few years, even more than cardiovascular. In COVID studies, it's very common to use time to recovery. It's a very defective measure. And one of the reasons it's defective is that about 4% of the patients who recover from acute COVID unrecover. And so if you recover, you're back home, about 4% have to go back to the hospital. And so if you recover, but then you unrecover, the unrecovery is completely ignored. And I don't think that's appropriate. Um, you gain power by using a high resolution outcome scale. So your best outcome scale would be something that's a continuous variable. such as blood pressure or some continuous function measurement. And if you have an ordinal outcome, the power of the treatment comparison increases as the number of levels of the outcome increases. So your ideal ordinal outcome, let's say you had a 100 patient study, your ideal ordinal outcome would be to have 100 levels, and you have only one patient at each level, because then it's a continuous variable. You could analyze that with a Wilcoxon test, which works great for continuous data. And so having as few ties as possible is going to maximize power. So you don't need more than one person per category in the study. If you have fewer categories, let's say you have a 5-level ordinal variable, but the 5 levels are well populated. So there's not 80% of the patients at just one of the outcome levels. You'll have really good power gain over doing a responder analysis or any sort of binary outcome. You'll have a further gain if you use multiple outcome scales because you might be capturing different kinds of things such as quality of life and patient function and certain physiologic outcomes. That will gain power. And then you have a further gain by using longitudinal data. So if you could have more of a continuous outcome measured multiple times, you're going to have the really gold standard sort of clinical trial design with maximum power. And while you're doing this, you need to take death and other clinical events formally into account. So when you're doing sort of a classic longitudinal analysis, it gets hard to do that and to take clinical events formally into account without having something that's hard to interpret, such as a competing risk analysis that doesn't really penalize you enough for things like death. You need something else. And ordinal analysis is really a key to solving that problem. So power and making the most of the sample size that you're given has increased importance in rare diseases because if your power is only 0.9 or 0.8 in a common disease with thousands of patients, it's just going to go down from there. So anything you can do to keep from losing power by having higher resolution patient outcomes is going to be extremely beneficial and it's going to make studies feasible. Now, one thing I didn't put on a slide that I wish I had is what happens in practice. This is very distasteful to statisticians, and most of them will tell you they feel used and abused when they're asked to get involved in this. But somebody will have a rare disease with a binary outcome, and then they'll tell you that the minimum clinically important difference is a 50% reduction in the risk. And so they may say, let's say mortality is the outcome. 50% reduction in mortality is going to be minimally clinically important. Well, that's not true. That's called placing your hopes on a dream. And the MCID, minimum clinically important difference, is going to be way less than 50% reduction. So what we see is people gaming the system to pretend to get good power. And so when they say that they're powered to detect a miracle, and the only thing that happens is a clinically important benefit of treatment, they have nothing at all. So when you power a study to detect like 3 times the MCID and all you get is the MCID, you're not able to say anything. And so a fundamental principle of statistics that really, really needs to be respected is maximizing information extraction from the raw data. There are some cases such as RNA sequencing data, single cell analysis, where the information is so dense and is so high dimensional that statisticians like me don't know how to deal with it, that we rely on other people such as bioinformaticists to do data reduction into lower dimensionality that we can deal with. It'd be better to use the rawest form of the data, but use the rawest form of the data that you're able to process. That's how you preserve power. Now, in terms of designing randomized clinical trials, what are some aspects of outcomes that you need to take into account? Well, having things that are important to the patient is a growing recognition at regulatory authorities as well as sponsors and academic researchers that we need to be more conscious of what's important to the patient. The single biggest pitfall here is if you have an unblinded therapy, you'll get a lot of concern from regulatory authorities that you're asking patients how they feel, and if they know what treatment they're on, they'll give you a biased answer, which often is the case. So you do have to pay special attention to blinding or masking in this setting. But it's very important to include things about how the patient feels and functions, not just clinical events. Um, if you have a functional measure, for example, and then the patient is deteriorating so quickly that you can't do the test that the patient is getting to assess their function, or if the patient dies so that you don't measure the functional test after a certain point of time, then your outcome that you're studying, such as functional scale, is interrupted by the clinical event. And we see some studies where they're actually having as a main analysis the functional status in survivors. So I saw a study recently where there were more deaths in the new treatment group, and they analyzed only survivors, and they found a benefit to the treatment on a functional scale. That's really not fair. That's just covering the deaths under, putting them under the rug. So analyzing the functional status in survivors is not really a very interpretable or helpful thing. And so serious clinical events should be part of any outcome. You've heard in statistics and drug development this growing field of estimands, and there's a lot of good coming out of that field, but there's some frustrating aspects of it that a lot of time is being spent on defining and dealing with intercurrent events. And so there are many people that would say death or maybe the need for a rescue therapy is an intercurrent event. And then how are you going to take into account that when you're analyzing a functional scale or something else, or analyzing blood pressure? Um, I don't really think it's interpretable to not count these things as events. And so I don't really think of things as intercurrent events. I think of them as being part of the outcome. And when you do that, everything gets much easier to interpret. And to me, it gets more clinically relevant because you're able to say which treatment gives patients a better outcome. And the better outcome could include lowering mortality and then making those that didn't die have better function. So the fundamental outcome unit in an analysis is the current state of the patient on any given day. So if you just always remember what is happening to a patient on a given day and what's the worst thing that happened to a patient on a given day, that's kind of the fundamental clinical assessment. And if you can use that fundamental assessment, you're going to really have a high-powered analysis that doesn't require as big a sample size. And that leads to a longitudinal analysis. So if you analyze the current states over time within patient, you have a longitudinal analysis. And the most general way to think about that is with a longitudinal state transition models. So how do patients transfer between states, transition between states over time? Do people tend to require a mechanical ventilation as their lungs fail, and then do they tend to transition to dying after that, or do some of them able to come off the ventilator, or some of those able to go home? So if you think of things as state transitions over time, it opens up an amazing world of clinical trial design opportunities as well as analytical opportunities. So if you can reduce the patient status to an ordinal scale on a given day, and then you include clinical event overrides at the top end of that ordinal scale, you'll be able to cover a lot of things in a very interpretable way based only on observable quantities and not based on having to deal with intercurrent events or certain interruptions to the flow of data collection. Now, there's some analytical options that are gaining traction in the last few years. There's a win ratio and win odds, and now there's a new method of win time, and there's desirability of outcome rankings. And these are longitudinal extensions of the Wilcoxon two-sample test. So we're seeing those used more and more, especially the win ratio and win odds. And they gain power by breaking ties and a time to event outcome. So especially with the win ratio, it sort of starts with time until an event such as cardiovascular death or all-cause mortality or some bad clinical event. And then because the death rate might not be that high in your sample, it says we're going to look at all possible pairs of patients. And then if both of these patients are still alive, um, as of a certain moment, we're going to break the ties in their survival time by ranking them in terms of their function or quality of life. And so you look at the clinical event first, and then you look at all the other things. The DOOR method looks at the patient's outcomes in a global perspective, where clinical experts have to sort of compare the patient, one patient to another in a holistic way on the basis of all the bad things that happen to each patient. Um, Now, both of these methods, they only give a within study estimate. In other words, you're calculating the probability that a randomly chosen patient on treatment B has a better outcome than a randomly chosen patient on treatment A. So that is the guts of the Wilcoxon test and the proportional odds logistic model. And that is a very useful quantity, which has been called the probability index in the literature. The question is, that's not a clinical readout. So you don't really translate that to a clinical metric. So if you ask yourself, patients given treatment B tended to have better outcomes than those given treatment A. If you ask yourself how much better, you don't really know. You just know that there's a high probability of being at least a little better for B versus A. But we really want to know how much better. And then we want to know what is the outcome of patients on a specific treatment. So we need to have those descriptive statistics that are compatible with how we're comparing treatment A and B. So we'd like to be able to give an outcome metric summary for any given treatment. And when you go past two treatments and you want to compare among three treatments, then DOOR and WIN don't really apply anymore. And if you need to give statistics that inform your readers about how patients fared on treatments A, B, and C, you don't really have a metric like that. And then there's some technical problems with the method. The relative ordering estimate is influenced by the narrowness of the study inclusion criteria. And so if you had a narrower range of outcomes on some sort of grand scale, then your probability of B being better than A will shrink. So it can be a function of the inclusion criteria. And this is sort of like reporting a t-statistic in a comparing two means in a clinical report without actually giving the difference in means. And so we don't really want to look at a treatment difference in standard deviation units. We want to look at a treatment difference on the real scale, like blood pressure. And then it's very, very difficult with these measures to deal with missing component data, and it's very difficult to do meaningful covariate adjustment. If you have sensor data, because part of what you're doing is time to event, these methods are functions of the censoring distribution. You know, when you do Kaplan-Meier estimates or the Cox model, and you have censoring, a distribution of censoring times, incomplete follow-up times for people who haven't had the event, those don't really affect the Cox model results or the Kaplan-Meier estimates. So you don't really want to use methods that are disturbed by the censoring distribution when you can help it. The methods assume that the treatment affects all outcome categories equally, which is not necessarily the case. So I want to turn to a more general approach that's more of a linear way of thinking. It's a formal statistical modeling approach, which is ordinal longitudinal models. This extends the Wilcoxon test and it extends the Cox model to allow for covariate adjustment and repeated measures. And it's a very flexible way to model longitudinal data that applies for all kinds of data, including continuous data like blood pressure. And so it uses a Markov process for an ordinal state transition model. And we have shown with multiple clinical trials that the within patient serial correlation is handled very accurately by using a first order Markov process. So a first order Markov process says that when you're looking at a patient at a given visit, their tendency to have a bad outcome on that visit is a function of how poorly they were doing at the previous visit and at baseline, but not in visits previous to the previous visit. So you just need to use a lag one or previous visit status is what predicts your outcome on the current visit. Um, by modeling the intrapatient correlation better, you increase the effective sample size. So let's say you were using a random effects model for long-term follow-up study. It's been shown that that does not capture the patient correlation very well, especially if you're using a random intercepts model and not a random slopes model. But even sometimes with a random slopes model, you're assuming a correlation pattern that is very unrealistic in human studies, especially with longer follow-up. So if you don't model the correlation pattern within patient accurately, you don't get accurate standard errors, and that will distort your alpha and beta, your power and your type 1 alpha in the frequentist sense, and it can mess up your or lower your effective sample size. When you're using an ordinal longitudinal model, you're elegantly handling missing components, which I'll show you an example of that. And it's the only method that really, really elegantly handles absorbing states that preclude the patient's scales from being assessed. So an absorbing state would be death. You could have cures. So you could have a small proportion of patients being cured and they're free of disease forever. That would be a second absorbing state. And the method handles that very elegantly, very explicitly. You're accounting for death and the need for rescue therapy. The underlying statistical parameter in the model that I'm going to be talking about is a transition odds ratio for treatment. And then from that, you can translate this to an amazing variety of clinical readouts. So instead of oversimplifying the raw data to a responder analysis and then losing all of your power and not being able to handle missing component data, you're translating the full information statistical parameters to a clinical readout. So you can translate this model to the probability of transitioning to a state Y2 at time T2, given you were in state Y1 at T1. So that is a kind of a time-dependent way of thinking about things that's akin to a hazard ratio in a Cox model. Uh, Probably more clinically useful, what's the probability of being at severity Y or worse as a function of time and treatment? What is the mean time in any set of states? What is the difference between treatments in the expected time in specified states? This would be like the difference in time to recovery or time to loss of function in another setting, but this will handle unrecovery and other complications. So translating probabilities into mean times in various states, I think the clinical audience finds the time-related estimands to be the easiest to interpret and often the most clinically relevant. So we tend to stress these. So this generalizes the Wilcoxon test, it generalizes the Cox model, it generalizes recurrent event analysis, and it generalizes standard longitudinal analysis um, in a number of ways. So this would be one of the most popular clinical readouts of an ordinal longitudinal model. This is from a study of acute respiratory distress. This is the Violet study. The treatment was vitamin D, and there were 4 outcome levels. So being at home, so you were successfully treated and discharged home is your desired outcome, and that is the good end of the scale. Your next worse outcome would be that you're in the hospital or a health facility like a skilled nursing facility, but you don't have respiratory distress. You're not on a ventilator. Your next would be you're in the hospital and you're on a ventilator, or you have acute respiratory distress syndrome actively, and then death would be the worst outcome. So you can see the deaths, the proportion of deaths is always increasing because that's an absorbing state. The other states can increase and decrease over time because they're not absorbing states. So patients can move in and out of these states until you get to death. And then going at home, you could count that as an absorbing state, or you could leave it open because some patients do need to return to the hospital. So you can see the proportion of those that have the best outcome is growing over time, and it kind of plateaus here at 28 days. This is a beautifully designed study that had these four levels assessed every day for 28 days with almost zero missing data. And so what the clinicians have found most useful in summarizing these models are charts like this, where you're showing these stacked bars with the proportion in each state as a function of time and then a function of treatment. And you could subtract these two to create kind of a difference plot if you wanted to. But I think these what's called state occupancy probabilities are extremely intuitive and clinically interpretable. Now you get a big efficiency gain from having multiple assessments per patient. In that study, where we had daily assessments for 28 days, if you just picked one day at random, and let's say it's day 14, would be a pretty good one to pick. What was the patient's status at day 14? Well, that gives you one outcome for one patient. So the effective sample size, if you only had that day 14 measurement, the effective sample size for that patient is one. What if you had, uh, let's say, five measurements? That patient who has five measurements has the information content of about uh, two patients that had one measurement apiece. If you look all the way out, the 28 daily measurements gives us the information content of having one measurement for almost five patients. So each patient, if you use the full longitudinal data, which is 28 observations per patient, each patient has the power and efficiency value of more than four patients. So you could say that every time you have about six observations, uh, it's like having a new patient added to the study. That's a very powerful thing to make use of. And when you can't get a large grand total number of patients, having more frequent clinic visits is a way you can control if the expenses are not too great for getting a reasonable sample size or increasing power. Um, Now, this is an example that is just hot off the press, and one of the key authors of this is uh, is on is here today. I was glad Matthew Shanshin is here, and he can comment on this. Please feel free to, Matthew. Matthew is one of my close colleagues at Imperial College London, and in this study, Orbiter 2, which was just published, I guess it was a few days ago, maybe. Um, the basic data that being collected are daily angina frequencies, and an ordinal scale is created from that. And then Matthew and his colleagues worked very hard to figure out what's the best way of handling rescue therapy. Somebody who needs anti-anginal meds, um, they need to be given a penalty for that because they might be partially controlling their angina. They're modifying the natural history of angina. So if it takes you a lot of medicines to keep your angina frequency down, you have this magnifier here that's added to the ordinal outcome. And then you have clinical events at the top of the scale. So Matthew not only did all the analyses for this in a very brilliant way, but he agonized over the best graphical display for this. And Matthew, maybe you could chime in and tell us about what you did here.
Oh, thank you. I wasn't expecting to have to talk. I thought I'd have a listen, but thank you very much. So we this was from the Orbiter series of studies, which was a RCT where we actually tested having stents against placebo, where we pretended to put in a stent, or my colleagues did, and we had an original study, Orbiter one, which surprised everybody by being negative. So we kind of went back to the drawing board and thought, well, if we're doing Orbiter 2, we better work out how to do it and see what the most sensitive way of detecting an improvement in symptoms. So when we went into it, we're very worried, what happens if, they have less angina because they've taken more tablets? How does this interact? And things like that. So the ability to combine two ordinal scales and say, well, you could have no angina, one episode of angina, two episodes of angina on no anti-anginals, and then kind of do a matrix like that, I think was quite appealing to us and allowed us to kind of have this kind of very clinically relevant outcome. And we also at the top end had saturating events such as people who died or people who needed emergency PCI for MIs. So we have this in some ways slightly complex matrix, but in other ways, as you look up it, you get increasing units of angina, but as the gradation of hues, you get increasing episodes of angina. And it took a little while to get it, but I think we kind of got it in the end. And one of the nice things that you can see is that day zero, people, there's always a slight shift immediately after you've done the intervention. And then over time, you can see the kind of number of episodes of angina just slowly come down with time. And you can see changes in the number of units of anti-anginal usage over time as well. And yeah, that's kind of how we do it. Sometimes it's easier to see the breakdown graphs. I will admit that sometimes I do prefer the breakdown graphs, but we liked this as the primary outcome because we didn't need to take a punt and say, how do you compensate for these two conflicting endpoints?
And one of the cool things here, Matthew, is you've got 77 levels of outcome, and then you've got hues here, different hues depending on the level of medication needed by the patient as a function of follow-up time. And then you have the saturation or the how pale the color was to indicate the number of anginal episodes. So you've got all of these things sort of coded in here in a very cool way. And I know you spent a lot of time to come up with that. So I think this is our best example of an ordinal outcome with a lot of levels still being very manageable. And I think one of the most important take-home messages for people is that this kind of data is a gold mine. This is rich, rich nuggets of gold. And when you have data collected, and there's a lot of work that went into mobile app and other things for patients to be able to do this. When you have data collected on a daily basis for 84 days after randomization, and then you have it down to this level of information. So by the time you sort of add together the resolution this way with the resolution this way by having a daily data, this is such super high powered statistically that it's one of the highest powered endpoints I've ever seen. So any other comments you'd like to make, Matthew?
I hope you're going to show the intervention arm as well, and
No,
show
no,
the
I just took
effect.
a subset here.
Oh
Uh,
no,
But I would refer everyone to the paper which is listed here, and it's an open access paper, so it's quite readable, and you can see what Matthew was just talking about. So I love this example, and if you were to do a power simulation for this way of doing things, you'll find the power is off the charts here. This is just super, super high information clinical outcomes. So ordinal and also the analyses used Bayesian methods, which I love to see in practice. Ordinal longitudinal models works for treatments that improve the patient's condition as well as treatments that slow progression. So it works for all kinds of settings. We have a detailed case study here, and then we have a project underway at FDA to reanalyze an ALS trial using this method, and it's really a fun case study, which will be published sometime, hopefully in the next year. This paper just came out in Statistics in Medicine. Max Road is a PhD student of mine who I'm very proud of. And Max wrote this incredible tutorial that goes into tremendous detail. It's extremely readable, lots of graphics, lots of examples, lots of code. And this is like the go-to publication that just came out in last month. Fantastic paper, highly recommend it. So what is the model that we're actually talking about? This is the only equation I'm going to show. This is the first order discrete time Markov proportional odds model. So x bit here is 1 over 1 plus e to the minus. So this is the inverse of the logit transform. So that's the logistic distribution function. And so the probability that at time t sub I that the patient will have status y being greater than or equal to little y. So let's say you have a 10 level outcome and you're currently modeling the probability that it's greater than or equal to 3 as a function of the baseline and of the previous visit's outcome status is this logistic model. So this is the form of a proportional odds ordinal logistic model. And you have standard covariates here. And then this is usually going to be written with regression coefficients. This will usually be a pretty simple function, but I wrote it more generally. This is just a function of the previous state and time. And so this is how you bring in that Markov property. But in terms of how you analyze the data, this is just another covariate. This doesn't add any software complexities to how you model it. And now the thing about a proportional odds model, this indexes little y. So you can see these are intercepts, and you have a separate intercept for every possible level of the outcome other than the very first level. So once you get to the second level and above, all of those have their own intercept. These intercepts can be unequally spaced, and that's a property of having an ordinal model. So the current state depends only on covariates, and your measurement times are T1 to T sub m, and that gives rise to this model. The assumptions are transparent. The assumptions are verifiable. So those are all key ingredients of the model. And then until you get into the state occupancy probabilities, you're using just standard software to fit the model. And the way you get the state occupancy probabilities is you have to get these sums of multiplied transition probabilities. That's the way that you uncondition on the previous states. In other words, you're marginalizing. So what you're going to get is state occupancy probabilities, which are intentioned to treat quantities. In other words, these are prospectively defined quantities, unlike transition probabilities, which are more like time-dependent hazard ratios, which are not ITT quantities. They're not prospectively definable with a causal interpretation. So we do the causal interpretation on the state occupancy probabilities. If death is the only outcome, the transition odds ratio is just a hazard ratio. The state occupancy probability is the cumulative incidence of death. And so let's do a general example where we want to calculate a state occupancy probability at 6 months. So you might be calculating the probability that the patient's functional ability is worse than Y, or the patient is dead. Or you can calculate the probability that the patient has an outcome better than Y and is alive. So those would be two probabilities you might want to calculate. And if your times are equally spaced and you want to calculate the mean time in one of these states, then all you do is to sum the state occupancy probabilities, and that gives you the mean times. For example, the mean number of days alive and well, or the gain in the number of days alive and well due to the treatment. So you're translating the treatment effect to the time scale to make it easier to interpret. And that's easier to interpret even if you have a time by treatment interaction required in the model. So this is a unified approach because it'll handle regular longitudinal data, ordinal outcomes interrupted by clinical events, multiple absorbing states. You're handling serial correlation in a way you can check to see if it's accurate. If you use random intercepts is equivalent to conditioning on the average of all previous outcomes without giving any favoritism to the most recent outcome. Whereas the Markov process is giving favoritism to thinking that the patient's previous state is more informative on their current state than the older patient status. So here's examples where, first of all, you just have death and you have somebody followed weekly for 3 weeks and they were still alive at the end of 3 weeks. Your longitudinal data is just 3 zeros. Somebody that dies at 2 weeks, that's an absorbing state. The data terminate there. And so your raw data is just a 0 and a 1. If you had 4 states, including hospitalization, myocardial infarction, and death, a patient who's hospitalized at 3 weeks, rehospitalized at 7 weeks, they have a heart attack at 8 weeks and stay in the hospital, and their follow-up ends at 10 weeks. Well, here they're okay. They were hospitalized. They went home, hospitalized again, heart attack, still in the hospital, and no more data. So that's what a longitudinal record looks like with 10 weeks of follow-up. And this is a more general case. You've got a 0 to 6 quality of life. You've got a heart attack, stroke, or death as clinical overrides. The quality of life varies, and it's not assessed on this patient in the 3rd week. But we know that in the 3rd week, the patient did not have an event. So they're not doing terrible. We just don't know the quality of life. So what their raw data looks like is you would tell your analysis software that you observed a quality of life 1, 2, somewhere between 0 and 6. These quality of lives, and then if you know they didn't have a stroke or die here, but you don't know whether or not they had a heart attack, their outcome could be either a 5 or a 7. So what goes into your statistical analysis is you would have this as interval censored. This is a special kind of censoring, and you handle that with maximum likelihood or Bayesian modeling, no imputation required. So it handles missing component data in a very elegant way. You could have hundreds of levels. This would be more like the example that Matthew went through. You can extend this to allow the treatment effect to vary over outcome categories. And so the treatment could affect mortality differently than how it affects quality of life or function or symptoms. If you put a Bayesian prior on that, you can put limits on the amount of borrowing that the treatment effect estimate should be able to get as you go across categories. So for example, if you thought the treatment effect should be totally borrowed from functional status to mortality, then your Bayesian prior would be just a point, and you're really assuming proportional odds. And if you relax that assumption, you're using the partial proportional odds model. So you have this very natural way to relax the assumption of the treatment having the same effect on different parts of the outcome scale. You might have a Bayesian posterior probability that the treatment affects death by more than 1.5-fold differently than it affects patients' functional status in a Bayesian analysis. So there's a blog article that goes into details about borrowing information across outcomes. And then I'm going to briefly talk about composite outcome scales. This is where you have lots of elements, and I think the ordinal longitudinal model approximates what we would really like to have is a patient utility for the current status of the patient. We would like to be able to say, with this constellation of symptoms and function, that's a utility of 0.2. And let patients tell us how to put all this together and what matters to them. We're sort of approximating that in a very simple way by just asking what's the worst thing to happen to a patient on a given day, and we're assuming you can order those things. Now, what if you had multiple scales and you can't combine those into an ordinal scale? This is something I've seen in like neurodegenerative disease studies where there's multiple scales. You might have a scale for the measuring arm function and a scale for leg function, and it may be beneficial to look at both of those. And so you have multiple scales at a given time. This is a common way of dealing with it. I really don't recommend this. It's just getting p-values separately for each scale, each type of scale, and trying to put those together using Fisher's method of combining p-values. That's a very, very non-clinical approach. You could do a time trade-off study and actually analyze utilities, but it's difficult. You could do an ordinal regression to relate all the scales to an ultimate outcome or to some patient global satisfaction scale. You're using an anchor, and then you could project all the scales into a single global scale for the ordinal longitudinal model. You don't see those things done very often, but they are possibilities. You could treat one of the outcome scales as an anchor that calibrates all the other scales to it so that then you can get an optimum weighted average of the scales that you treat as ordinal and add clinical event overrides. Um, you could put all the scales on the same Likert scale and ask the patient which function is most important to them. It may value walking more than things they do with their arms. And for each patient, you use the Likert scale of the thing that mattered the most to them early in the study. And this is often done in migraine headache studies where patients may value eye disturbance, vision disturbance versus headache versus nausea differently, and they pick the symptom that's important to them, and then you rate on a Likert scale 1 to 4 on that symptom becomes their outcome, and every patient has a different outcome pulled together. Kind of a wild idea, but I think the Bayesian approach is going to ultimately be more logical. This is where you just analyze multiple outcomes as a multivariate problem, and you allow these outcomes to be correlated using random effects that link the different outcome models together, or you use a copula, which is a very nice way to model dependence within a patient on multiple scales. And how you might actually use that is to say, we've got M different outcome measures, and we want to calculate the Bayesian posterior probability that the treatment benefits at least Q of these. So let's say you had 5 different outcome measures. You might want to say that your treatment is successful if the patient gets benefit on the majority of those. So Q would be 3. And so you calculate the probability that at least 3 out of 5 outcomes were benefited by the treatment without caring which 3 it was. You could calculate the Bayesian probability that the treatment has any effect on some of the outcomes and a major effect on one particular important outcome. So those are just give you some ideas of handling multiple scales. And I've got here in the slides a bunch of um, supplemental material that will go into more details about many of the things I've covered. And so I really appreciate your attendance today. Look forward to some questions and discussions, maybe some controversy.
Thank you very much, Frank. And thank you to Matthew for a great improvisation. It's an unexpected surprise, I guess. So please do turn on your cameras, raise your hands if you'd like to ask Frank a question. It would be much nicer if you ask questions on camera rather than typing them in the chat. But if you can't, at least do add your question to the chat. Frank, while people are gathering their thoughts together, I have one question for you. I know you're dealing with cardiovascular disease, which is very far from rare, but you gave a really excellent example of ALS. What happens at the FDA when they get a submission where the company did what is very suitable for them to show the effect and look the responder rate for rare diseases? Is there any push to reanalyze the data using a more appropriate ways, or not really? What happens in these situations?
It's really a tough question because sometimes the disease is so rare that there's not a lot more that can be done, and sometimes a sponsor will come to a regulatory authority as seeking approval of a bad idea. And that's what I would like to see changed because it's not needed. So a sponsor will say, what's the outcome that would have the lowest possible power? And they will choose that as the outcome because they did it in a previous study and they think they can interpret it. And the FDA is not really there to solve your problems for you. They're there to say that if you were to claim a benefit, you're not misleading people. They'll sometimes say, you're using a low power approach, but we're gonna be a little more worried about uh, approving something that doesn't work. And so if you want to shoot yourself in the foot, we're not gonna criticize you too much. So this is where sponsors really need to show leadership and to find ways to use the raw data and to measure better scales that have more information in them for comparing treatments.
Thank you. Faye, please go ahead with your question.
Thank you, and thank you so much for a wonderful talk. One of my questions is that the clinicians in my field, which is in epilepsy, seem hesitant to adopt this ordinal outcome because they will say this is not an FDA approved endpoint. Has any drugs like been approved using this kind of outcome?
And epilepsy is kind of an interesting case because I've seen people do responder analysis in epilepsy. This is almost criminal to say our outcome is going to be, did you have more than 2 seizures in a certain time period? And they totally ignore that one patient had 3 seizures, another one had 40 seizures. They counted those the same. That's not right. And you can't do stuff like that. I'm sorry. That just should be illegal in most countries. And so the first thing you need to do is to not make something a yes or no outcome. You need to use the number of episodes. But if you think of seizure as a longitudinal observation, you'll get an even better analysis because then you can model a non-constant rate of seizures over time instead of just counting the number of seizures over time. So longitudinal analysis is going to be better. But to your point about how do you get regulatory authorities to accept things when they're used to seeing bad precedent? They're used to seeing bad analyses that should not have ever been approved, but they were approved, and they set a little bit of a precedent. So what sponsors have to do is to realize that when you're showing somebody something they're not used to seeing, you have to do more homework than if you're showing them something they're familiar with. And I've talked to sponsors who have had just tremendous back and forth with regulatory agencies. And over time, I've had a wonderful collaboration that's led to something much better. And the initial response from regulatory might have been, we want you to do a simpler analysis. And the response doesn't even comment on the tragic power loss that the simpler analysis had, but it was familiar to the regulatory folks. But then the sponsor pushed back and gave all the reasons and simulations and references. And so essentially, every time I see a pushback on a particular technical thing, I write a blog article about it. So I've got like so many blog articles that help give people ammunition on these things that I hope you'll find that pays off.
Yes, I'm finding a lot of your work and articles really helpful, and we're trying really hard to influence the clinicians in the field, but it's going to take time. And when they do ask, are you aware of any new drugs being approved based on this powerful ordinal outcome approach? Are there examples that I can readily provide to them?
Oh, there's several things have been approved on an ordinal outcome with an ordinal analysis. I don't know of anybody who's compiled the list, but it should be searchable. And so, but I think the more important thing to realize is doing your homework and being persistent. It's just like when you're working an investigator, where the investigator says, I want to use a method because I publish in this one gastroenterology journal, and they always do the t-test for this thing. And I want to do the t-test. So the first thing you say to that investigator is, I'm not going to question you on gastroenterology, but statistics is my field. And I can tell you that a t-test is not appropriate for that particular thing, no matter how many times it was published in your journal. And so statisticians have to really take to heart that their number one purpose of collaborating is never to give somebody what they want. Just write that off. You're not there to give somebody what they want. You're there to give somebody what they need. So we start with this on the individual investigator level, then we sort of move up to, say, regulatory.
Thank you, Frank.
Thank you so much, Professor Harrell.
Joycelyn, please go ahead with your question.
Thank you so much. Lovely presentation. With the ordinal models, do you check for the that the Markov property holds as you would, say, for a traditional Cox regression or multi-state model? If so, how? And then the second bit to that is, do you always look on a day scale? Or if you're saying looking at observational data where events and measurements come in at different units, is there any way to harmonize away from using a day scale?
Yeah, the harmonization when you have different measurement schedules is one of the bigger challenges with the discrete time methods. The continuous time multi-state models have some advantage there, but they don't allow you to have ordinal outcomes, to my knowledge. So, but to your question, you can look at the visit before last and see if it influences the patient status at the current visit once you adjust for the previous visit. So that's an assessment of whether second order Markov would improve the first order Markov. The other thing we do more often is you add a patient effect. So when you add a random effect to the model, you can see if that changes anything, and are the random effects small? So what's the variance of the random effects? And I have examples online where I've done this sort of thing, and the random effects had a very small variance and it didn't change anything. And so that's a really good way to look at the adequacy of the first order Markov. We routinely add random effects and just see whether you need it to. So that's a very easy thing to do, even easier than adding in the second order Markov stuff. The other thing we do is we make variograms a lot. So make a variogram where you look at all possible pairs of follow-up times, calculate correlation coefficients, and compare those to the correlation that the Markov model assumes. That's one of the most stringent assessments you can do. I've got examples of that. And I think in that new tutorial, there's examples doing that.